Thank you.
All right, welcome everybody. Thanks for coming here. This is actually my first talk on this topic in many years. I was demoralized after the last bout of healthcare reform, but was delighted when asked to speak for this conference, because one of the reasons I was demoralized is I think that big monies were largely represented in the previous round of reform, and I think tying these two issues together is of utmost importance. So I'm here representing Physicians for a National Health Program, which is a nonprofit research and education organization based out of Chicago. And we have more than 18,000 physicians, medical students, and health professionals among our ranks. So the first thing I want to talk about is the uninsured. As many of you are aware, we have for many years had many Americans that without access to health care because they lacked insurance. And the number of Americans without insurance has been steadily rising over the last several decades, with a slight decrease recently with the Affordable Care Act. In the setting of this as well, fewer Americans are covered by private insurance. And the blue bars here represent projections with essentially subsidies to the insurance company through the insurance industry through the Affordable Care Act. Being uninsured has consequences, and so if you don't have insurance, it's going to be pretty hard to get appointed with a physician, specialist, other care providers. One of the other consequences is increased morbidity and mortality. This was a study from a large representative sample, the NHANES study, National Health Evaluation Nutrition Study, which captured a representative sample of the country and rigorously screened them for a variety of medical conditions, sociodemographic factors, controlling for medical conditions, socioeconomic status, and a whole variety of health behaviors and risk factors. Not having insurance was associated with a substantive increase in a significant increase in mortality. And applied to the country, we can estimate that 44,000 people die every year just by lacking health insurance. To put that in perspective, because these numbers are often hard for my brain to conceptualize, that would be deaths, loss of the populations the size of Mason City and Newton, Iowa every year. So people being uninsured has consequences, and these consequences are tragic. A less spoken about problem, because it's harder to measure, is underinsurance. And I'm going to argue that some of the measures of underinsurance are inherently problematic. A common measure, for instance, is having more than 10% of your annual income in health bills. That requires two things, right? It requires an insurance policy that's not covering you completely, and it requires being sick. And so a number of people that aren't sick could find themselves underinsured with the next illness. And so we grossly underestimate these numbers, and there's no consensus on how to define it. One definition that sometimes people use to avoid the problematic definition that I described is how high is your deductible for your insurance plan. This graph is not going back decades, I'm afraid. I'm afraid this graph is going back but 8 years. And in the past 8 years, deductibles have been rising, and rising fast. So the percent of people with deductibles over $1,000 has gone up from 10% to 41%. I suspect most of you have anecdotally had some experience with either you or loved ones talking about your deductibles and hearing numbers that were previously unheard of. This is becoming, unfortunately, the new norm. These deductibles are especially frightening because most Americans do not have the resources to pay these sort of deductibles, which means essentially foregoing care if you have a high deductible health care plan. And these costs cause problems for people with high deductible plans. So you'll see here, this is comparing those with high deductible plans to other health plans, and you'll see they're more likely to incur debts, use up their savings, have trouble paying for food, or cut on retirement savings. And skip care. And so those with high deductible plans are more likely to not visit a provider when sick, more likely to defer getting preventative care, getting a particular test or treatment or medication, or for that matter, even not just seeing a doctor, but seeing their regular doctor as well. Kids without care. So this compares children that have access to free care, 25% copay or 95% copay. That latter group you can think of like a health savings account that a number of people on the right have promoted as a solution to the crisis. And you'll see here that, that as the copays go up, guess what? People are less likely to get care. It's not rocket science, but the data is there, and it's a problem. People that are underinsured and uninsured are more likely to delay seeking care for a heart attack, and that has mortality outcomes. So this was a neat study. This is a clinical trial, and so they randomized people that had insurance to getting better insurance or to keep their same insurance. And the better insurance essentially would cover all the drug costs for beta blockers, ACE inhibitors, angiotensin receptor blockers. And guess what? The people that had full coverage, they were less likely to have a repeat event, another cardiovascular event or mortality. So providing better coverage equals better results. And there's other studies like this as well. This is not limited to heart attack. There's been studies of asthma, childhood asthma, diabetes, cancer. Beyond medical risk, morbidity and mortality, there's financial risk to having poor health coverage. It's been estimated that 62% of bankruptcies in this country are the result primarily of medical bills, and 3/4 of those people had insurance. So this is not just not having insurance, but a number of people. Just because you have insurance does not mean that you're protected from bankruptcy or financial ruin. And I don't know how many of you have seen the story about a kid with cancer or a loved one with cancer, that where the church or some other group is having a fundraiser to pay medical bills. Everyday people with their current health plans can face financial ruin if they become sick, and it's unacceptable.
It's higher than that in Iowa. I'm a bankruptcy lawyer, and it's probably closer to 75% in Iowa.
75%.
That consumer bankruptcies are driven by medical.
Thanks for sharing that. And it has been steadily rising too, so that certainly doesn't surprise me. We talked about the injustice, but the injustice also discriminates among socioeconomic and racial lines. The gap in life expectancy between those that earn above average and below average, and again, this is above the median and below the median. I'm not talking about top 10% versus bottom 10% here. Just being above versus below median. Look at the difference in life expectancy, and it is not narrowing. It is widening. Similarly not narrowing is the income gap between blacks and whites in this country. Not narrowing. Uninsurance. Again, if you are a black, Hispanic, or minority group, you are more likely to find yourself uninsured. And I'm sure the underinsured statistics, which are much harder to come by because of the definitions, are even worse. So think this is not equitable. The administrative costs with the system are not going down. So this is a graph since 1970, and you'll see here the growth in physicians and the growth in administrators within the healthcare system. They do not seem to be following the same track. Where is money being spent? And so these are the profits from a variety of people in the industry. So you see pharmaceuticals, insurers, and suppliers making a large amount of money in the system. And you'll see a number of white men and one white woman here that are also doing quite well in the current system, reaping large amounts of pay and holdings. We also have another HMO CEOs that are doing all right for themselves these days, while others suffer. U.S. prescription drug spending continues to rise. Oftentimes people will cite that research and development is one of the reasons for that rise. You'll see here that research and development represents a small part of the pharmaceutical budget, and actually much of the R&D is actually happening through support of the basic and clinical sciences through National Institute of Health funding. And then those discoveries are then taken off through the pipeline. And industry is certainly much better geared for getting products to market. If we relied on academia to get products to market, we would be in trouble for sure. So I talked a lot about pharmaceutical industry, insurance industry as far as administrative costs, but I think it's also important to recognize the role that providers are playing in this as well. And so we have a large administrative overhead for insurance companies to try to cherry pick healthier patients in their plans, because guess what? You save money if you have fewer sick people in your plans, because sicker people cost more. and trying to make it more difficult for more expensive services to be provided or denying those outright. But providers as well are trying to bill as much as they can for the services that they're providing from the insurance. So we have two large sort of administrative bodies sort of competing against each other and raising the administrative costs in the system, which is quite inefficient. Here are some examples of upcoding. And so there's a science of sorts of making folks look sicker on paper. And so you'll see here that slight changes in the way diagnoses are written result in greater billing for physicians in hospitals. And so these are essentially the same thing, but the slide on the right gets extra credit. And the electronic medical records, which were thought to bring savings to the system and have been a big push lately, the hospitals that are receiving them are getting much more efficient at upcoding and coding in a manner that is more efficient for billing. And so you'll see here the hospitals that received incentives for electronic record keeping had much larger increases in claims over that period. So this was the answer to the quote-unquote solution to this problem that came up with the most recent round of healthcare reform when Obama took the presidency, and that was a mandate model. And sort of the gist of this is that they're sort of what are defined as essential benefits. So no standard package, there can be different plans that come into play. For preventative services, copays and deductibles are eliminated, but for all other services, they're still certainly in place. One of the goals, there was concern about this administrative overhead that I talked about. How could there not be? It's so huge and such a huge piece of healthcare costs in the system. So one of the goals was to limit costs to 15 to 20% legislatively by saying that this is the cap that you can have on overhead. Everything else needs to be spent on healthcare. No regulation of premiums, deductibles, or copays. And they're out-of-pocket caps, but there are ways sort of around that by having services themselves or drugs themselves that are not on the formulary and subsequently not covered. So you might think you're protected by having a particular cap, but if you get a certain type of cancer and that cancer drug isn't covered under that plan, you could easily go out of your out-of-pocket maximum for that year. This is what happened, and so there is certainly partial success here. So this is the graph of uninsured. My previous graph zoomed in on 1970, and so that's why it looks a little different here. But you'll see, as enacted, the burgundy is what we expect to see from uninsured. And again, this is not underinsured, but uninsured. And a number of states, as you know, are opting out of the Medicaid expansion in the Affordable Care Act, and if they indeed opt out, which is looking like is likely, then the blue would be what would be most applicable here. So certainly it's still an unacceptably large number. I would say any number is unacceptable because it implies inequity. This is what things would be like next year without and with the ACA. And so what you'll see here is the uninsured section of the pie is shrunk, which is good, from 18% to 10%. There's a Medicaid expansion. And then I think you can lump the exchanges with private because these are private insurance through the exchanges. While I dislike these general plans here, it is nice to have sort of summary images that give you a sense of what the plans are. So the exchanges offer 4 types of plans: platinum, gold, silver, and bronze. And the actuarial value of them is 60, 70, 80, and 90%. What that means is that on average, for the people on the plan, the insurance plan for the silver plan, for instance, which is the most popular plans right now, insurance would pay 70% of all care, and the client would pay 30%, which is a frighteningly large share and a growing share, certainly from what we've seen historically. That can be done through a variety of ways. And so earlier I criticized deductibles. And so deductibles is one way to make sure that the consumer is paying on average about 30%. However, to be a silver plan, you have to sort of meet this criteria. And I do think that it's nice to have a simple way to be able to visualize, because otherwise these plans are impossible to read and understand. Even as a physician, I find this system and even individual plans very difficult to navigate.
But after you do the deductible, then you get the 30% off.
No. It's not 30. It's 30% on average. 30% on average. So that means, like, if we have a group of 100 people in this plan, they're going to be paying about 30% in the insurance, 70%. Not that everyone pays 30%. But if you have a high deductible, so the other piece that they're picking this up is co-pays, which would be a standard payment for a product. So like if you have to pay $10 or $20 for every prescription, or co-insurance, which is a percentage. And so it might be 10, 20, 30% of all care. And so a silver plan that has a high deductible is likely to have lower co-pays and co-insurance, and one with a lower deductible likely higher co-pays and higher co-insurance. And so the same plan, to balance these things, there are a variety of factors that need to be considered. Here, this gives you sort of maybe a better picture of what sort of things you're looking at. Again, the average deductible for plans of each of these. So you'll see the bronze and silver plans have to have higher deductibles because there's a greater share of the cost that's being borne by the consumer. I think it's also worth making consideration, what was the average employer plan before this? So we get a sense of what these plans look like. And you'll see here the average deductibles for the previous employers' plans were quite a bit lower. So these products, in general, some people are picking the platinum products, but the bronze, silver products, and silver being the most popular right now, are closer to being underinsured than anything else. So I think we've spread some costs to decrease uninsured by increasing the underinsured. Here's another way around that as well. And so the plans. So part of this legislation was to prevent discrimination of sick by not being able to enroll someone because they're sick. But guess what? You cannot cover HIV medications on your formulary. So that's one way to sort of get around that, right? You can allow that person on your plan, but that doesn't mean you're going to pay their medications. And you'll see here a non-random sample of things from 3 plans of what they're not prescribing. You'll see conditions that tend to be associated with increased utilization or increased costs for that condition themselves. A number of plans are not including the medications, even the generic medicines, here on their tier. So that's one way that they're sort of getting around it. Here's another way, by calling certain drugs specialty drugs and having a separate copay for them or a higher coinsurance with them. And so these things are very special, hence why they use the word special repeatedly through the line. Because they're special, they're going to cost more. Also, and I don't know much on the details of this, but there was this story that was broken about changing accounting practices to book some administrative costs as if they're medical costs to try to get around this 15 to 20% cap. I don't understand how the accounting practices for that work, but there's been concern that that's going on. But in spite of that, actually overhead does not appear to be reduced. And so you'll see here, a weighted average of the 9 firms, we're still looking at about 17% for overhead. And it's been estimated actually that under the Affordable Care Act that overhead is not likely to decrease, and if anything actually may increase in spite of that effort to try to rein that in. And these are projections from the CMS Office of the Actuary. Anyhow, so that was what came of our reform, and so it's quite a mixed bag. And it made the cover of the Lancet, a very prestigious British medical journal. This was literally what they put on their cover after this went through. The healthcare reform process exposes how corporate influence renders the U.S. government incapable of making policy on the basis of evidence and the public interest. I think that's a pretty powerful summary, and pretty powerful also as well to just put it on the cover of the Lancet. It's also, I think, worth noting a number of people criticize other plans that really do seek to try to provide coverage for everyone as being too expensive, but we're actually already paying as much in public funds as countries that are providing care for everyone. So this is public spend, or this is total spending for a variety of countries that are of similar sort of socioeconomic situations to us. You'll see here 2 things. One, we spend way more than everybody else. About twice as much more, in fact. The other thing you'll see is the public money is the blue bar. We're already publicly spending more than all the countries except Switzerland. And so we are already spending enough public money to do what others have been able to do, which is provide care for everyone.
Can I stop you for a second?
Yes.
How much of that difference is due to provider reimbursement? How much of that's due to administration? How much is it due to the fact that we have national epidemics of obesity and other diseases?
Yeah, so I'll talk about that some, although it's really hard to sort of parse that out exactly. The easiest one of those to parse out is the administrative overhead piece, and I'll have some slides talking about that. In general, obesity is one area where we are sicker than these other countries, but there are other areas where we're healthier as well. So for instance, our smoking rates are lower than almost all of these other countries. Not all of them, but certainly most of the European ones. So as far as sickness goes, not likely. It's not due to an aging population either, because our population isn't older than these other countries. It certainly is a lot younger than Japan, for instance, which has a very old population. But great question. Some people will say, well, we're also a wealthy country, so looking at dollars is not fair. We need to adjust it for sort of our wealth. So this would be adjusted for wealth. I have every single country here that participates in providing this data to the OECD. And you'll see here that even after adjusting for our gross domestic product, we're really just sort of completely in left field here. I mean, there's no one that's in the same ballpark as us. The red line I put for all my other slides is going to be where we're at. I put it at where half we're at, and so you can see that we're spending approximately twice as much as everyone else. And I would argue that we are not getting our money's worth. So this is how it's trended. Increasing health costs as a percent of GDP has gone up internationally, and that's because we do have more care available, and the more modern cares are more expensive. But we can compare ourselves to what happened in Canada here, for instance, and we can look at the timeline and see that this is actually when their program was fully implemented. And this difference in cost, I think, is our sort of uniquely American solution to providing health care. This is a difference in US and Canada for administrative costs. This is per capita, so 2,300 of that you can say is likely administrative from that first slide, which is not all of it. But we can at least say that about 2,300 of it is related to administrative costs, at least based on this comparison. And unfortunately, we're not getting more. And so this is related to access. This is the number of people that cite difficulties in paying medical bills or where cost was a problem to access. And you can see we lead the world in this category. And this is true actually even for Americans with above average income. So this is comparing, this was again above the median income for our country compared to other countries. So even those in our country that should have the most resources were more likely to not get a medical visit because of cost, not get, it should say test instead of text or treatment, not filling a prescription, and so problematic. Are we getting more in terms of life expectancy? So these are sort of comparable countries from the OECD, and you can see that we're not living longer. Are we doing better with infant mortality? I'm afraid that we're not doing better there. We're not doing better in terms of maternal mortality. And some people, another question related, how much is related to overuse of care? And there's some evidence of that, but in general, we're not getting just more care in general for basic things. USA, not getting more sort of hospital days, so it's not like we're getting more inpatient care. Japan's an outlier. I'm not sure why that is. Physician visits per capita, it's not like we don't get to see the doctor more, so it's not like we're getting more services necessarily. Although I do believe we're a leader in like MRI scanners per capita and a few other categories. U.S. doctors are more likely to face hassles from getting coverage for providing prescriptions for their patients. When I encounter this, it's the least favorite part of my job, but I do love my job, so I do it. But it's not unusual for me to, if I have to sort of put an appeal in, to spend a half an hour trying to get a single medicine for one of my patients, and that's a half an hour that I could be seeing somebody. And it's not totally surprising that physician satisfaction is not high in the country as well. In fact, there's growing physician support for national health insurance. Speaking of sort of bias in surveys, these surveys are infrequent because most of the surveys actually don't even include this as an option. But this is a survey that was repeated twice. And you'll see here that in the most recent survey in 2007, the majority of physicians were strongly supportive or generally supportive of national health insurance. Americans as well, but again, they're seldom polled on this. They're usually polled more specifically about a policy that's going in place right now. Let's see, I can shut this down. Let's postpone it. How about 4 hours? All right, there we go. But you'll see here, even among the general public as well, popularity is increasing, but it's not, doesn't appear to be on the table. Economists are somewhat split, but you'll see here in this survey more favored a candidate-style reform than an employer mandated or a tax credit. The closest plan right now is HR 676 in the House. It's been there for a long time, as long as I've been in PNHP. It currently has just slightly under 15% of the House co-sponsoring it. It would cover everyone, be comprehensive with no co-pays, a single public payer with simplified reimbursement to reduce the overhead. It would slash the overhead piece dramatically. No, it would not allow investor-owned HMOs or hospitals. I didn't include that on here, but they actually have worse outcomes and increased costs. Improved health planning and public accountability. Biggest threat to this sort of system, though, of course, is underfunding. Any national system can be underfunded, and there's certainly risk of that. So that's certainly the drawback. I would argue that we can do it. We're already spending enough public money to do it. We already have good hospitals and well-trained professionals. Research is not strengthening, but it is still strong. And like I said, we're currently spending it. So what's in the way? And this conference tackles that head on. What's in the way is that we are being governed under the influence, and there are large corporate interests at play. This is my final slide. This was an editorial I wrote about 5 years ago, calling Senator Grassley out on some conflicts that he had in money that he had taken, and he was involved in the committee that was considering reform. The final paragraph talks a little bit of what I think is a summary of the problem here. So I have a couple, I think I have maybe 1 minute for questions, and I can be contacted outside of this. Yes?
One quick, simple question
Yeah.
and a more complicated question.
Okay.
I understand that there was a documentary being done on Quentin Young's life.
Yes.
Is that completed?
You know, I don't know if it's completed. I actually donated for them to do that. It was like being crowdsourced or whatever, but I actually don't know if it's completed. So,
And then the lengthier question, I see
Yeah.
that you're a psychiatrist.
yes, that's correct.
What do you recommend that we do about the sociopathy of the current bunch of Republicans?
And some Democrats.
Yeah.
I mean, is it simply a reaction with the pitchforks? Is that how we have to
So-
take care of them?
I'll tell you what. This is part of how you guys got me here. Is I think you guys are on the right track in calling attention to the core problem here, which is that there's a number of people that are governing with very conflicted interests. And as I say in the last line here, it requires re-identification of the American public as the real stakeholders. So during the healthcare reform, there were a number of quote-unquote stakeholders, which largely included health insurance and pharmacy executives that were involved in the inner circle of meetings. I can tell you Physicians of the National Health Program was not involved in any discussions or invited in any discussions. Yes?
How do we get access to your PowerPoint? Is there any way that we can get a copy of this PowerPoint?
Yeah, I'd be happy to give it to you. So you can either email me, and I believe I also gave a copy to Dawn. So my email is mkejess@yahoo.com. And if you can also, if you Google my name, you can find my email as well. I'd be happy to give you a copy. Yes?
Maybe we can add a new term to the DSM that would be money-induced schizophrenia.
Some sort of term. I have some other terms as well that I won't share. Yeah. What's that?
You had 70% as the average administrative cost for the private insurance.
Really a great job on a very complicated issue.